So this is a 19-year-old gelding, Polish warm blood that was used for dressage. On presentation in October 24, oh my goodness, October 24 of 2017, he decided to run into a gate. It was a metal gate, and developed a very large hematoma on the left shoulder. And you can see the pictures, how what these pictures look like on the left shoulder. This particular area that you see here, which I am highlighting, that is the spine of the scapula. And these holes that you see over here is atrophy of the supraspinatus muscle and also the infraspinatus muscle. All right. And this is the video of the horse. And I realized today we have an awful video streaming. So you might just have to take my word for it. But he is about a 2 to 3 out of 5 lame on that left front. He has a head bob when the right front hits the ground. So it's about a 2 to 3 out of 5, especially on the circle to the left. Now, this is the horse on a straight line. And on the straight line, you can see that the horse also does have a head bob. Right there, it has a head bob when the right front is in the ground. Someone was knocking the door. All right, you can see that. So not horrible, but definitely lame. And let's go to the other side. Good. So I'm not sure if you guys were able to see the lameness because I know the streaming is not perfect, but just take my word for it that the horse has a 2 out of 5 left front. And then the horse also had a short cranial face of the stride on the obviously on the left leg. Now, what are we going to do with this horse? How are we going to evaluate this horse? We are going to take radiograph. We already did the physical exam and we already saw the obvious things. We should do an ultrasound, and then we can do a bone scan or not, but it's definitely not a requirement to do. But check out this radiograph over here. Not really, not horrible. The radiograph of the shoulder were not super horrible. However, I must say that the radiograph did have the shoulder did have a lot of joint fluid. Now check out this ultrasound over here. This is a very interesting ultrasound because it shows absolutely no muscle at all. What you see here, what you're seeing here is the intramuscular fibers. That's what you see, the intramuscular fibers. There's no muscle fibers on this horse, zero muscle fibers. Right here, all this is that fascia, the intramuscular fascia that every muscle has. And right here is where I'm telling you that that horse actually has quite a bit of increase in joint fluid in that shoulder. So what is the conclusion? We have suprascapular neuropathy, suprascapular nerve that is damaged. We have shoulder instability due to the trauma, and obviously due to the lack of lateral support. What that does is it creates more instability, becomes a cycle that creates fluid in the joint. And that fluid in that joint creates arthritis because of the instability of the joint. So what did we do? Well, we tried to quiet down that instability with some steroids, right? We put a little bit of Kenalog, or which is triamcinolone. We put a shade with amikacin. because there was a paper in 1997 that supported the idea. So we're trying to do what was supported by science. So what else could be done? You could do the decompression of the suprascapular nerve for the treatment of surgery, for the surgery treatment, and that was done in November. So the idea is to take that nerve that is being pinched, decompress it, and ideally it will release all those nerve impulses. So the electricity of the nerve will come back to normal. Then we still rest the horse for a little bit. We gave him anti-inflammatories, We also gave him some gastroprotectants, and then we started the rehabilitation technique. During rehabilitation, he got shockwave, he got magnet wave, he got laser, and he got underwater treadmill for strengthening of those muscles. So the underwater treadmill is supposed to get that. It's supposed to get that to get that going. The horse also did get electroacupuncture, by the way, which I did not mention here in the. He got regular acupuncture, electroacupuncture. He got what else? I'm not sure what else, but got a lot of stuff. That was answering Valerie's comment. And so we gave the owner a good prognosis for survival and a fair for performance. Okay, so this is the horse after a month. So that was walking. Here's him trotting. So we decided that after 1 month, we saw some improvement, not some, but we saw some improvement. So we're super encouraged by what we saw. And we're very happy. We continued the treatment, and 4 months later, he actually went home. And this is him working up at home. You can see that the muscles did not completely come back actually, but he did get better, he did get sound, and he was able to go back to work, because the beauty of it is that a lot of those other muscles will compensate and pull the leg forward. These muscles over here, right here, they will start pulling that leg forward. Some of you might remember from vet school the omotransversarius, the cleidocephalicus, cleidobrachialis. A lot of those cool muscles will actually start picking up the slack and help out to bring that leg. And that's where the underwater treadmill was so good for this horse and the physical therapy. So, well, let's discuss this case a little bit. I just told you that those fibers, what were those fibers? In the ultrasound, all the muscle is gone, and you can see those intramuscular fiber, the intramuscular fascia. The suprascapular nerve injury was the cause of it, right? So there are several type of nerve injuries, and I'm not going to go into it, but there are nerve injuries that cause inflammation, and there are nerve injuries that completely cut the nerve health. And that's probably what happened on this horse, obviously. And the synovial effusion I already told you is because that scapulohumeral joint gets weak because it doesn't have the proper instability. Because remember, that shoulder is the joint that does not have any collateral ligaments. So without collateral ligaments, there's not a good stable joint. So, here's I talk a little bit about the peripheral nerve are susceptible to the onset of trauma. And this, if maybe if we would have attacked this horse with regenerative therapies right after the injury, maybe we would have saved that nerve. But there's no telling. There's absolutely no telling. We do know that the nerve was there, and it's much easier to go retrospectively thinking, oh yeah, we should have done that, but there's no saying. The horse came to us about a month, I think several weeks after the injury did happen. So we can speculate that maybe we could have helped him a little bit. Etiopathogenesis, this most of the time is trauma, like in our case. However, abrupt abduction and protraction could cause this, and a very abrupt movement on the horse could definitely cause it. Now, the epidemiology of it, it is a rare condition. It's not really a common condition. It can happen on any breed, gender. There's no predisposition on who gets it. Of course, it's mostly traumatic, right? And the interesting thing is that the suprascapular nerve is just in a very particular spot over the scapula, that if you hit it at the right time with the right pressure and the right position, you will cause that damage. And several papers will show that, obviously. And here's a little bit more. Do not fall asleep, and do not fall asleep here. But here's a little bit more about the types of damage. And I'm not going to go that deep, but we have neuropraxia, which is the one you have mild compression. Then you have axonotmesis. Look at that, axonotmesis, which is caused by crushing with damage. All I want you to know is crushing with some damage, but it basically the capsule of the nerve is preserved. And then you have neuromesis, which is when it completely severs all the nerve areas. So we suspect that the second, either second or third, the middle, or the last one is what happened in our case. Then once you get this nerve damage, whether neuropraxia, axonotmesis, or neuromesis, then you have what's called neurogenic atrophy of the muscle. Remember, they could be neurogenic atrophy, or they could be non-use atrophy. It's kind of that saying, hey, if you don't use it, you lose it. That is the non-use atrophy. This particular one is neurogenic, meaning we damage the nerve and we cause that damage. Okay, so causing instability, and of course everything that you guys saw before. Not a whole lot on the importance of this particular slide, but for those of you going into sports medicine and rehab, you should know a little bit about these three type of damages. So here's what I was telling you, where the nerve crosses. You see how the nerve comes out of the cervical vertebra. You see how it's coming out, and then coming out from the cervical roots and going towards the scapula. So you can see in the picture of the left, in the left picture right here, how that nerve is just so exposed right here over the scapula. And you can see on the picture of the right, how it comes from the cervical to the scapula, and how easy it would be to actually damage it right here. So this is gonna be a quiz tomorrow morning for Santiago and Camila, right here, where that nerve comes from. So the surgical treatment was proposed by Dr. Stachak, and what it does is that it releases the pressure of that nerve, like I told you. And I'm running out of time, so I want to give you some time for questions. But basically, the papers found out that 8 horses did good, 3 didn't, and it's basically one of those surgeries that you need to catch at the right time, at the right moment. And here is where what they did for those horses. Some of them had mesotherapy, some of them had electrostimulation, and some of them had regenerative therapies as well. I guess 8 out of 3 is not bad. And if you consider our horse went to full athletic performance. So I guess that's a success, right? But that muscle never came back. Very, very important to understand that when we have these horses for the owners. And there's a bunch of other papers on it, and that talk about this particular this particular syndrome. The interesting thing about this is that if you look at those cases, those papers, they're very low in cases, right? You have the 27 cases here, you have 58 over here. So it's not like it's a super duper mega common thing that we have a whole lot of research on it. But nevertheless, I think that we have a good handle on it, and we do good managing this disease. Cool deal. Now I can open it up for questions. No questions. Okay. Okay, good. I know where I lost.
Come on, guys. Let's wait some questions for Dr. Rullan.
No questions. That's good. I know where I lost you. I lost you in this slide over here. Neuropraxia, axonopmesis, and neuromesis. I'm sorry I had to put that in here for you. Sorry I had to put it, but it's cool to have some neurology over here. All right, guys. It was a pleasure having you here. I hope you learned something today. If you didn't, just go back to the books. It's all in there. Promise you.
Thank you. Thank you very much.
Thank you.
Thank you.
Thank you.
You guys have a great day. Bye, guys.
Bye.
Bye.
Hello.